Hi, this is Jonathan Levy from Holy Cross Health in Fort Lauderdale, and I'll be reviewing the technique for reverse shoulder arthroplasty for acute fracture. This is a case of a 78-year-old female who presented with a complex proximal humerus fracture. In addition to the fracture of the humerus, there is clearly a fracture of the anterior glenoid that you can see both on the axial CT scans as well as the three-dimensional CT scan. So here you see a coronal CT scan that helps to understand the complexity of the proximal humerus fracture as well as the fracture of the anterior inferior glenoid, which is best seen on these three-dimensional reconstructions. This is from the MatchPoint software available through DJO and Materialize. But you can see there is a significant glenoid fracture that could be incorporated into a surgical plan. So here you see the MatchPoint software, which is used to place the base plate utilizing the anatomic center line, reaming down to the level of the fracture, and anticipating that you might reduce the fracture utilizing something like an anterior glenoid retractor, and use the peripheral screws of the base plate to secure the fracture simultaneously. This is a deltopectoral incision, and the greater and lesser tuberosities are disrupted through the interval that typically occurs just posterior to the biceps groove. The tuberosity can be mobilized, much like a lesser tuberosity osteotomy, and a suture can be placed as a traction suture and identification suture for the lesser tuberosity. The same will occur in the greater tuberosity, and the goal at this step is to separate the greater and lesser tuberosities from the humeral head. So here the humeral head is exposed, and rather than popping itself out, I used a oscillating saw to remove a section of it, and the remaining section would be removed by rotating the humerus around. And here you can see the rest of the humeral head is removed. The anterior glenoid is then exposed, utilizing three retractors: a posterior fucuda, a superior bent Homan retractor, and an anterior glenoid retractor. The labrum is then removed to expose the entire glenoid and visualize the anterior glenoid fracture. You can see that the glenoid exposure is quite easy in the setting of a fracture, as the tuberosities are out of the way, making the exposure pretty straightforward and allowing you complete visualization. The challenge here, of course, is the glenoid fracture, which you can see encompasses probably about a third of the glenoid. The inferior capsule can be removed, and in this case, that anterior glenoid retractor is being used as a reduction tool to reduce the fragment into a more anatomic position. The MatchPoint guide localized the starting point just posterior to the fracture line, still using the anatomic center line such that the drill path exits the anterior glenoid neck. You can see in the reference screens, which I actually will print out during the operation to allow reference during the surgery. I drill bicortically, followed by a tap on power. I measure to make sure that the depth is correct, and I've obtained at least 26 to 28 in this case, millimeters of depth. So here you can see the power tap. I'm advancing bicortical. There's a laser line at the depth that corresponds to 30 millimeters. And then I can ream. I like to use circular reamers in the setting of an acute fracture of the glenoid like this, so the half-moon reamers don't catch on the fragment and displace it. Here you can see I'm reaming the surface, including the glenoid fragment of that fracture. I've got bleeding bone, which allows for bone ingrowth onto the on-growth surface on the back portion of the base plate, which is porous metal. The tap is then removed, and maintaining the same trajectory, the base plate is advanced. As the base plate advances, maximum compression is achieved. The goal is to get the greatest amount of compression between the bony bleeding surface and the backside of the P-squared surface of the base plate. Typically, this can be achieved by creating a maximum compression. The peripheral screw guide is then placed. The center screw is advanced to finger tight. And the four peripheral screws are then prepared. These are 5 millimeter lock screws. The drill guide helps to prevent cross-threading and maintains the trajectory of the fragments. So here you can see, even in the areas where the fracture occurred, I'm able to obtain bicortical purchase. Here you can see posterior bicortical bite as well as anterior. Here I'm levering on that anterior glenoid retractor, which helps to maintain the reduction of that glenoid fragment. The sleeve is removed, and then the screws are advanced. I typically will advance on power using the inferior one first, and then the remaining peripheral screws. So here you can see the base plate is placed. I've obtained fixation of the fracture, and I'm ready to place the glenosphere, which in this case is a 32-4, as the female is an average size. This creates 6 millimeters of lateral center rotation offset. Base plate is inserted, impacted, and then the taper is tested with both torsion and pull to ensure that the Morris taper is properly engaged. The set screw is then advanced, and we are now ready to approach the humeral side. The greater tuberosity is mobilized by placing 3 number 5 ethibond sutures sequentially, starting at the supraspinatus level and extending along the infraspinatus down to the teres minor. These will eventually become the horizontal fixation sutures between the greater and lesser tuberosity. These are generally passed through in front of a brown deltoid retractor, utilizing a number 5 ethibond, which has a very large needle. The tuberosities can then be mobilized sufficiently. Here you can see the second and third horizontal sutures being passed, and they are generally clamped to a single clamp. At this time, you can begin to think of the additional sutures that are going to be placed into the greater tuberosity. These will include sutures that will cerclage around the stem itself. Here you can see these are doubled over suture tape sutures. 2 of them will be passed and later used as a racking hitch placed through the holes in the stem and around the greater tuberosity. This is all about secure fixation of the greater tuberosity to the stem. The fact that I am using sutures to secure the tuberosity to the stem necessitates me utilizing cement into the humeral canal, as the rotational forces may exceed the press fit that you achieve. Finally, a fiber tape suture is placed inferiorly. This will be a cerclage suture that will be placed through the medial hole on the humeral component around the greater and lesser tuberosity, completely cerclaging the entire fixation. This has been shown by Mark Frankel to have the optimal fixation for the tuberosity. Here you can see that being placed pretty low, as the medial hole on the shell is quite low as well. I believe Dr. Frankel actually won the Neer Award for that paper many years ago. So by placing all of these sutures ahead of time, it really allows you to not have to struggle in placing the sutures once the component is cemented or impacted. So the humerus is then exposed utilizing Hohmann retractors anteriorly and posteriorly. Humeral head reamers are then used to determine the canal diameter. And here you're looking for a gentle amount of chatter. You're really not looking for reaming so that you actually ream the canal. I then assemble the trowel to the shell. In this case, this is a small shell and a standard length component. And I impact it in 30 degrees of retroversion down to the level where the shell matches the calcar. And you can see from the lower portion of this picture that the humeral shell is actually lined up right with the calcar, maybe a millimeter proud, allowing me to impact it a bit if I had to. This provides the optimal location and stability, but I'll still trial by placing a standard neutral component in to make sure that it is easily reducible, and then I can bring the greater tuberosity around into an anatomic position. So I'm satisfied with the tension, and I'm ready to prepare the humerus for cementation. But before I do that, I must place 2 additional sutures, in this case fiber wire sutures, through the shaft, and these will become the future vertical sutures between the shaft and the tuberosities. I place a suture in and out of the humerus to create a bone bridge on either side. These sutures can also be used to create a double row fixation, as sutures at the rim of the shell can be placed first and then tied to these sutures, creating a suture bridge over the tuberosities. And we'll show you that later. These sutures are then snapped and will be used later. So these are the sutures I was speaking about on the rim of the humeral component. So once I take the final component, I place sutures as mattresses in the top hole and out the sort of the top and bottom holes of, let's say, the subscapularis footprint as well as the greater tuberosity footprint. And those will create mattress sutures superiorly as well as anteriorly. I'll take a clear-cut glycerol cement plug and now I will prepare the stem before I cement. I will take the deep side of the fiber tape and place it through the medial hole on the humeral component. This will be my cerclage suture and will later be passed around the lesser tuberosity. And then I'll use a passing suture to advance the suture tapes, which are doubled over, through both of the holes of the fin. So the anterior and posterior fin at each level will have one doubled over suture tape that has already been passed around the greater tuberosity. This will be a cerclage between the greater tuberosity and the actual implant, providing secure fixation of the greater tuberosity to the shell. It's very important to recognize the correct orientation, that the sutures should be placed through the posterior hole and then into the anterior hole, and then I snap it on the other side to make sure it doesn't pull back. So here I'm just using a number 1 Ethibond suture as a passing suture. You certainly could use some form of suture passer as well, and this is basically being used to shuttle the doubled over sutures on the deep side of the greater tuberosity. These are the suture tape sutures that were previously placed. And here you can see shuttling that inferior doubled over suture tape suture. Sometimes you create a little bit of a suture ball, so you have to redo that step, which is what I'm doing here. Great. So now I've got all of my sutures passed through the stem, and I'm ready to begin the cement process. Snapping all the sutures on the outside so that they don't get stuck or pull out. And we'll be using the black and tan technique. This involves injecting cement into the canal when it's a little bit runny. I'll then remove the upper centimeter of cement and replace it with humeral head bone graft. The bone graft is actually placed and pressed in very strongly. And what this will create is an incredible grout. In fact, the time zero fixation of this is quite remarkable, much better than if you didn't use that bone in terms of getting initial stability, even when the cement has yet to cure. And what this is doing is creating an interface between the cement and the tuberosity bone that needs to heal. So here you can see the humeral component is placed on the jig in 30 degrees of retroversion. I'm getting the alignment. I can't press it down by hand. I have to mallet in. And I'm going to mallet it down all the way down to the level of the calcar. Sometimes I will mallet it along the face plate of the screw, the set screw that holds the guide in place, as it gives me a 135-degree neck shaft angle impaction. But here you can see a piece of that calcar had broken off, but when I reduce it to give me an idea of the height, it reduces perfectly such that the calcar is lined up with the shell. Now, if you're using the standard shell, you must make sure that cement is not extravasated through the osteotome slots, which are not on the small shell. So once I am confident that the humeral component is in the correct place, I can impact the poly and reduce the shoulder. Now, I typically will wait till the cement is cured before I do that. And now I'm ready to repair the tuberosities. So the first step I'll do is take the rim sutures. These are fiber wire sutures. Remember, we created a mattress between the anterior hole and the posterior hole. The anterior hole, when the shoulder is in 30 degrees of retroversion, is going to line up right with the anterior portion of the supraspinatus. And I'm going to pass this suture first in the infraspinatus, which is the posterior suture. And then I'm going to pass the anterior limb through the supraspinatus itself. So that bone tendon junction, and this is going to set my height, ensuring that tuberosity is going to line up right with the shell. So you can see that the anterior supraspinatus lines up perfectly. So I can tie that down and it's going to set my height. Now I'm going to later use these sutures and tie them to the sutures that were placed into the humerus, those vertical sutures, and it creates a transosseous technique, almost a double row. So I've already passed my graded tuberosity sutures, so I'm ready to tie them down. So here I'm taking the superior suture tape, which is a racking hitch suture. It's around the graded tuberosity through both of the both of the superior fin holes. And I can just ratchet it down. And this is really going to secure that graded tuberosity down in place. And the second suture is just below it. This is the inferior racking hitch suture tape suture. I want to make sure it slides. Remember, it's sliding around the graded tuberosity through the anterior and posterior fin hole on the implant. And this is giving excellent fixation of the graded tuberosity to the shell of the humeral component. And I can cut these sutures. So now I have the graded tuberosity fairly well mobilized. And I'm going to now advance the sutures through the lesser tuberosity. So this is the number one ethibond suture that's mobilizing the lesser tuberosity. First, I'm going to pass the fiber wire rim sutures through the bone tendon junction of the lesser tuberosity, much like you do a lesser tuberosity osteotomy. Now, sometimes you get a good bite, sometimes you're through the muscular border of the supraspinatus, so sometimes I'll actually throw another limb of suture, an extra locking stitch into it if I need to. So I've passed those medial sutures, and now I'm going to take the horizontal sutures, the number 5 ethibonds that I previously placed through the greater tuberosity, and I'm going to begin to advance them through the lesser tuberosity. These are horizontal fixation between the greater and lesser tuberosity. So the top one, which is through the supraspinatus, is going to line up almost at the rotator cuff interval. And I'm going to snap it and move on to the next stitch. And I'm using a free needle to pass these sutures. So the first one went through the rotator cuff interval, and then the rest are going to go sort of bone-tendon junction of the tendon of the subscapularis. Making sure they slide. And this is the more inferior, sort of closer to the infraspinatus, and that will line up more in the inferior third of the subscapularis. And then the last suture is the cerclage suture. The fiber tape cerclage suture that has already gone around the greater tuberosity quite low, through the medial hole on the stem, and now very inferior on the lesser tuberosity. And once again, sometimes this is so low that I'll put a locking stitch through the muscular border of the subscapularis in order to have better fixation. Depending on the quality of the tissue there, a lot of times there's an anterior blowout that occurs, and the quality of that inferior subscapularis is quite poor. And now I'm ready to tie sequentially, top to bottom. This is the sort of rotator cuff interval, the horizontal sutures. And I'll sequentially tie and cut them. Placing an anterior Hohmann retractor allows you to really see that subscapularis quite well. I use this technique very commonly when I'm doing anatomic total shoulder arthroplasty. So I'm going to tie the rim sutures. I've sort of started by reducing the rotator cuff interval, and now I'm going to take the rim sutures, these are sutures that were placed as a horizontal mattress between the shell and the bone tendon junction of the subscapularis. This also sort of sets the appropriate height of the lesser tuberosity reduction. And now I can tie the remaining horizontal mattress sutures through the body of the greater tuberosity and lesser tuberosity. You can see that split compress. Sometimes help to have someone hold the knot. And so, to review, you're seeing the initial sutures were the tuberosity to shell. These are then the horizontal fixation between the greater and lesser tuberosity. We'll eventually get to the cerclage suture around the greater lesser through the medial hole of the shell of the stem, and then finally the vertical sutures, which will be through the humerus, the bone tunnel that was created on the humeral shaft, to the tuberosities. And I will integrate one of those sutures as the transosseous, meaning taking the rim sutures and securing them to the shaft, creating a transosseous equivalent fixation as well. So there are multiple ways of obtaining fixation of the tuberosities utilizing the sutures, many of which are passed through the rim and fins of the actual implant. So I just removed the number 1 ethibond in the subscapularis, which is no longer needed. Here is my cerclage suture. This is the suture, fiber tape suture, placed quite low. You can see there's not much quality tendon there, so I'm going to come in and create a additional locking stitch. Just to create some better fixation onto the lesser tuberosity. And this is once again that cerclage. Make sure you pull it real tight to get any redundancy out. We'll tie this and cut it. I tend to use a knife to cut all my high tensile sutures to not dull out my scissors. So here you see what's left here are the vertical sutures. These are the bone tunnel sutures in the humerus. There are sutures that were created as rim sutures on the sort of supra and infraspinatus as well as the subscapularis. Those are rim sutures that are left. So the first set that I'm going to place is going to be a locking suture all around the world, so to speak. This is going to go starting with the subscapularis and continuing to create a locking suture around the rotator cuff. Getting those rim sutures out of the way so don't lock those. Kind of rotating the arm around so I've got great visualization. I can get all the way to the posterior cuff. And now I'm tying them. I think these rotator cuff sutures are critical. I do believe that many times the sutures are strong and the bone is not, and you will cut through the bone tendon junction. So utilizing these locking sutures through the rotator cuff, I think, makes a huge impact. So in this case, the way those tied, they lined up quite well with the sutures from the subscapularis. So now I'm going to create a transosseous equivalent suture by tying the remains of that vertical sutures to the rim sutures on around the subscapularis bone tendon junction. And I'll cut those sutures as well. And so what remains are the superior rim sutures, the supra-infra rim sutures, and the humeral shaft sutures. So as to prevent those from slipping on themselves, I'll just tie a simple knot to secure that transosseous bone tunnel, and then I'll just tie them to each other. So once again, we've had, now that essentially creates a very solid fixation, and you can confirm this to a full arc of motion. You'll see there is no motion of the tuberosities at all. Hard to tell, but I make sure that I've got full elevation, that there's nothing stopping range of motion. There you can see complete rotator cuff reconstruction around the reverse shoulder replacement. Here are post-op AP and axillary radiographs showing not only fixation of the glenoid fracture, but near anatomic reduction of the tuberosities.